Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on Legionella outbreak investigations, a practical approach part one. This is part one of a series of 3 sessions that we have organized, and my name is Ginny Kim. I'm a physician lead for the Environmental and Occupational Health team at Public Health Ontario, and I have the pleasure of moderating today's session. So before we begin, I'll mention just a couple of a few housekeeping items. First, the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation, so hold your questions until then. And if at any point during this session you experience any technical issues, please email capacitybuilding@oahpp.ca. So finally, I would like to state that as a moderator of this session, my only conflict of interest is that I'm a shareholder in my partner's design firm. And with that, I would like to introduce you to the speakers for today's session, Dr. Austin Sigmund and Kelly Briscoe. So Dr. Austin Sigmund is a public health physician in health protection at Public Health Ontario. He completed his Royal College Fellowship in Public Health and Preventive Medicine at the University of Ottawa in 2021. His portfolios include environmentally acquired infections, for instance, legionellosis, blastomycosis, as well as emerging infectious disease threats, for example, mpox, viral hemorrhagic fevers, and sexually transmitted and bloodborne infections, and infection prevention and control lapses. His public health interests include communicable diseases, health equity, and LGBTQ+ health. Our second speaker is Kelly Briscoe, a senior program specialist on the Environmental and Occupational Health team at Public Health Ontario. She has a Master of Science degree in Food Safety and Quality Assurance, a Bachelor of Science in Public Health and Safety, and a Bachelor of Arts in Community Health Sciences. She's a certified public health inspector, or PHI, with over 15 years of experience in the environmental health field. So it's now my pleasure to pass it over to Austin.
Thanks, Ginny. So before we get started, I wanted to note that Kelly and I have no disclosures for this presentation. And although Kelly and I are speaking today, we would like to acknowledge our team members in environmental and occupational health, health protection, and laboratory services for all their contributions in putting together this round series. By the end of this session, participants will be able to describe an approach to Legionella case exposure investigation, describe the ecology of Legionella in human-made water systems, and outline an environmental risk assessment in a Legionella investigation. So in the first half of the presentation today, I will go through a background on Legionella, discuss the epidemiology and clinical presentation of legionellosis, and then finish with a public health case and outbreak investigation. In the second half of the presentation, Kelly will cover Legionella survival and sources in the environment, as well as an approach to environmental assessment for possible sampling. And we've also developed a case scenario that will flow through today's session and into session 2. And as a reminder, today's session is the first in our 3-part Legionella series. Our session 2 on May 16th will review environmental sampling, interpretation of results, and remediation measures to mitigate Legionella growth in water systems. And our third session on June 8th will describe a cooling tower associated outbreak that was investigated by Simcoe Muskoka District Health Unit, and they'll be discussing their lessons learned and approaches used to communicate with the public. And the registration for those sessions is forthcoming. So we'll get started with our case scenario. And with this, I want you to think about cases of legionellosis you may have worked on in the past and see if you can identify risk factors or common signs and symptoms. So we'll have an 85-year-old man who presents to the emergency department with 4 days of fever, chills, cough, shortness of breath, fatigue, and confusion. He denies having any chest pain and has no GI symptoms like nausea or vomiting. His past medical history is significant for type 2 diabetes, as well as chronic obstructive pulmonary disorder, or COPD, and he does have a 65-year pack history of smoking. So for Legionella, they are gram-negative bacilli, for which there are more than 60 species. And although various Legionella species can cause disease in humans, Legionella pneumophila, and particularly serogroup 1, is most commonly associated with disease. Legionella are found throughout nature, especially in freshwater environments like lakes and streams, and cases and outbreaks are often linked to human-made water systems like an air conditioning cooling tower and a hot tub. And Kelly will be going into more detail on sources of Legionella in her section of the presentation. So when we think of characteristics of Legionella, it is most commonly associated with water droplet transmission to humans through inhalation of an aerosolized contaminated water. So that's answer C. Other routes include through the aspiration of Legionella contaminated drinking water and less commonly soil, but we don't see Legionella being spread from person to person, so a period of communicability is not applicable to your case investigation. In the next slide, I'll talk about the two diseases that make up legionellosis, but I've listed their incubation periods here, so that is the time from exposure to symptom onset. For Legionnaires disease, it's 2 to 14 days, and most often 5 to 6 days. And for Pontiac fever, it is shorter, so 5 to 72 hours, and most often 24 to 48 hours. When we think of risk factors for acquisition of legionellosis, it includes an age over 50, a smoking history, an underlying chronic condition like diabetes, lung disease, or renal or kidney disease, or having an underlying malignancy or cancer, and having a weakened immune system. So legionellosis is a disease of public health significance, meaning it is reportable under the Health Protection and Promotion Act, or HPPA, in Ontario. And there are two diseases that fall under legionellosis. So a more mild disease known as Pontiac fever, and a more severe disease known as Legionnaires disease. There are some similar symptoms between the two, as you can see. So this can include cough, fever chills, decreased appetite or anorexia, malaise or fatigue, myalgia or muscle aches, and headaches. But what distinguishes the two is really the severity of illness. So there's no pneumonia seen with Pontiac fever, and this is commonly seen with Legionnaires disease, as well as some additional symptoms with Legionnaires like confusion and GI symptoms like nausea and diarrhea. And often with individuals who have Legionnaires disease, they are sick enough to require hospitalization or intensive care unit or ICU admission, and their illness may result in death. So we'll go back to our case scenario, and you'll remember we have an 85-year-old male. He has a significant smoking history and underlying diabetes and COPD, so has multiple risk factors for legionellosis. And he presented to the emergency department with some common signs and symptoms like fever, cough, and confusion. After he is assessed by a clinician, a chest x-ray was done, and this shows a right lower lobe pneumonia. And so he's quite sick and admitted to hospital. A variety of investigations were ordered, including a Legionella urine antigen test. And in session 2, our PHO laboratory colleagues will discuss in more detail the types of clinical tests for Legionella and their characteristics, but I will note here that as part of this patient or case's workup, they had a lower respiratory tract specimen for Legionella PCR and culture taken. And then the attending clinician started the individual on antibiotics. So now we'll go through the epidemiology of legionellosis in Ontario. And in this first slide, we present legionellosis case trends over a 6-year period from 2017 to 2022. You can see in the left-sided figure that the green bars are representing the number of cases by month. The purple line shows the average number of cases for that month over the past 5 years. And the blue line shows 2 standard deviations above this 5-year average. The blue line is important because we use it at PHO to monitor for a higher than expected number of cases, as this could trigger taking action, such as issuing an enhanced surveillance directive, recommending a monitored situation, or producing routine weekly or monthly epidemiologic summaries. The key takeaway for this figure for you is to note the seasonality in Legionella cases, with peaks that occur in summer and fall months and lows that occur in the winter and spring. The table on the right provides the total number of cases and the rate of cases per 100,000 population between 2017 and 2022. And you can see that the rate of legionellosis has fluctuated between 1.5 to 2.6 cases per 100,000 over the past 6 years. In this slide, we are showing the annual rate of confirmed Legionella cases by public health unit between 2018 and 2021. The gray color represents no reported cases in a given year. Green and light blue represents a low rate, and the darkest blues represent higher rates. And the key takeaway in this slide is that the rate of confirmed Legionella cases can vary quite widely year to year by PHO. And you can see in some years that a public health unit might report 0 cases, and then in other years, the same PHO might report a higher rate of cases. And overall, you can see a predominance of Legionella affecting mostly the southwestern and northern Ontario public health units. And then our final EPI slide, we report on the severity of Legionellosis in Ontario between 2017 and 2021. And so we've seen the highest rates amongst males and those over the age of 70. So that fits with the demographics of our case scenario. We also see that it causes a high burden of disease in Ontario. So of our confirmed cases, between 72 and 86% have required hospitalization per year, and deaths have ranged between 2.9 to 8.3%. So now we'll move into the public health management of Legionellosis and return to our case scenario. So you'll remember the patient or the case was diagnosed with a pneumonia, admitted to hospital, and had tests for Legionella. And so his clinical status has now worsened, and he requires a ventilator in the intensive care unit. And the Legionella urine antigen test was positive and is returned 2 days later. And because Legionella is a reportable disease, the local public health unit receives the confirmatory result, and a public health nurse is assigned to investigate the case. So I won't spend too much time on this slide, as the confirmed and probable case definitions can be found in Appendix 1 of the Ontario Public Health Standards for Legionellosis. And again, our PHO laboratory colleagues will be reviewing the different types of clinical tests that are used to classify a case. But in our case scenario, the individual had a urine Legionella antigen test that was positive. And this specific test only detects Legionella pneumophilus serogroup 1. And that's the most common type of Legionella that causes human disease. And so you can see that this individual will meet the confirmed case definition. So as we saw with the epidemiology slides, most individuals with Legionnaires disease have severe disease that require hospitalization. So it's possible that when you're doing your public health case investigation, that the individual or case may not be able to answer your questions, and you might have to rely on family members or medical records. And reflecting on our case scenario, there's a lot of information that we know through the medical records. So we know that this individual is a confirmed case because of the urine antigen test results. We know basic demographics, that he's an 85-year-old male. And we have a fair amount of clinical information as well. So we know the signs and symptoms that the individual presented with, like fever, chills, cough, and confusion. We know about his medical risk factors like smoking, diabetes, and COPD. We know that he had a chest x-ray that confirmed a pneumonia. And we know that he required a high level of care with a ventilator in the ICU, as well as that additional Legionella tests are pending. So an important part of the case investigation is identifying the potential sources of exposure within that 14-day incubation period. So the time from an exposure to Legionella to when the symptoms began. And this is where your case investigation might get more difficult if you're relying on family members to gather information and not able to get it from the case themselves. So when we're thinking of potential sources, it's important to ask about travel history, and this includes both within Ontario as well as outside of the province. I want to ask any questions that would include being at a residence, working in or visiting a long-term care facility, a retirement home, or an acute care hospital. And then you also want to get a very detailed history on exposure to water systems to try and find out where that exposure may have occurred. And so I've provided a long list of examples of questions here that you could ask during a case investigation. And this comes from the Centers for Disease Control and Prevention, or the CDC's Legionnaires disease hypothesis generating questionnaire template, which I referenced below. And these types of questions become even more important when you're investigating a cluster of cases to identify a common exposure source. You may also remember that PHO once had a Legionella case report form, but this was discontinued in June of 2018. I think some public health units continue to use this form at the local level, and although we can provide you a copy of this form, it's no longer updated. So we will return to our case scenario again. The public health nurse is able to identify or interview a next of kin because the case isn't able to answer questions and gets a fair amount of information. So we find out that the case is retired and lives with a partner in a condo building. He has had exposure to various water systems, including the condo amenities, like the pool and the hot tub. The condo has a rooftop cooling system, and the condo also has a decorative fountain in the courtyard. They don't report any travel outside of the city, and there's been no visits to a long-term care home, a retirement home, or an acute care hospital in the last 14 days. Our CD team comes together and finds a report from the public health unit epidemiologist that there have been 2 other confirmed Legionella cases, both with a urinary antigen test that have occurred at the same residence over the past 6 weeks. And so this should start raising some concerns for you that there might be a potential cluster of cases that are occurring at this same location. So I will wrap up on this slide to note that when 2 or more cases are epidemiologically linked by location and time of exposure, an investigation should be conducted to determine if there's a cluster outbreak occurring. And certainly if you have questions about a potential cluster and how to investigate them, including developing a cluster or outbreak specific case definition, please don't hesitate to reach out to us at PHO. As we will learn in the next part of the presentation, environmental sampling should be reserved for investigations involving facilities and disease clusters and outbreaks where potential common exposure has been identified. And then in session 2, our laboratory colleagues will provide more information on the utility of molecular typing of both clinical and environmental specimens and how this can potentially provide some more evidence for a source of infection. So I will now hand it over to Kelly for the second half of today's presentation.
Great, thanks very much, Austin. So we're going to move over to environmental sources. So as previously identified by Austin, Legionella bacteria naturally resides in many freshwater and soil environments. However, it's the growth of that pathogenic Legionella in human-made water systems that is a concern, as this is typically the source leading to human exposure. Legionella bacterium has a very complex ecology, which allows it to persist in even treated water. It has the ability to survive in various conditions by living within amoeba and biofilm. So the survival of Legionella depends on a number of factors. One is a suitable temperature for multiplication. The growth of Legionella may occur between 25 to 50 degrees Celsius, with the most ideal temperature for growth being between 38 and 43 degrees Celsius. There's also a concern if there's a lack of residual disinfection levels. Disinfection levels may not persist in the plumbing of larger buildings, so this is why some higher risk settings, such as hospitals or long-term care homes, might implement on-site disinfection, such as chlorine disinfection. And also, Legionella requires a source of nutrients. And some of those nutrients may include organic matter, rust or scale from within the plumbing system, or biofilms. Biofilms can grow on essentially any moist surface, and that can occur in pipes, tanks, filters, or faucets, for example. And so in general, at warmer temperatures, any wet surfaces that contain nutrients provides a favorable environment for biofilm.
Biofilm also can provide a source of nutrients for Legionella and provides additional protection from external stresses such as temperature fluctuations and disinfectants. Stagnation, scaling, and corrosion can also encourage biofilm. And once it's established, biofilms can be extremely difficult to get rid of and can be resistant to biocides and disinfectants. So this is why prevention, including maintaining water temperatures, maintaining water flow, and disinfection levels are so important. There's also external disruptions that can allow the entry of Legionella into buildings, and there's various building factors that can lead to Legionella growth. Some of those factors include construction work, which can create vibrations during the construction that can dislodge biofilm and can lead to colonization downstream of the construction. Also, water main breaks or water pressure surges can also be factors, as well as changes to the municipal water supply. So as we know, Legionella is acquired by exposure to contaminated aerosols of water. And because Legionella species are water organisms, it's not surprising that inhaled aerosolized contaminated water has been linked to a variety of water sources in Legionnaires' disease outbreaks. Essentially, a contaminated source must have a means of creating and disseminating aerosols that contain Legionella, and they are then inhaled or aspirated by a susceptible host. So water sites with both biofilm growth and potential for aerosolization are possible sources of Legionella growth, and many exist in the built environment. As we've seen in the previous polling questions, the main sources of Legionella are potable water systems or indoor plumbing, our cooling towers or HVAC systems, and non-potable water systems that would include spas or hot tubs, hydrotherapy pools, decorative fountains, and misters. So this brings up an important point to consider for prevention. It's not so much the source of the bacteria that's important, but more the conditions that allow it to thrive and survive. If we can remove those conditions, then we can move towards preventing growth. So as we've seen, Legionella is prevalent in potable water systems, and there are a number of factors that can contribute to outbreaks in larger water systems, such as systems in hotels or hospitals or long-term care homes. One factor to consider is that they're often complex systems with long sections of potentially small diameter pipes that can provide extensive surface area for biofilm growth. There's also old plumbing that can be a concern as it can experience corrosion or scaling, which can lead to biofilm growth, as well as heat transfer due to uninsulated pipes. This can lead to temperature decreases in hot water, but it can also lead to temperature increases in cold water, which can provide favorable conditions for Legionella. There can also be redundant pipe work or dead legs or dead ends that can allow for water stagnation. And stagnation can also be affected by water use or intermittent water use and the type of the setting. So consider for a moment water distribution in a small private home compared with a hotel that's at a capacity of 50%. So these would be very varying flows of water throughout the system. Hot water can also influence the incoming water temperatures, particularly when water is provided from a surface water source. So all of these characteristics together encourage biofilm growth, reduces temperatures and levels of disinfection, which can all lead to Legionella proliferation. So this is an image, a fairly simplistic schematic of a potable water system. And there's two essentially main types of hot water systems. There's non-recirculating and recirculating. It's been shown that in non-recirculating systems, hot water at the taps can cool to room temperature within 30 minutes. And this temperature decrease and possible stagnation of water provides an optimal environment for Legionella growth. So in an effort to prevent this cooling of water, recirculating systems circulate hot water from the water heater throughout the building and back to the heater, and provides hot water on demand and helps prevent Legionella growth. However, even recirculating lines are susceptible to heat loss and can also fall into that ideal temperature range for Legionella growth, particularly at those distal or endpoints in the system. So temperature is an important control measure and is a traditional means of preventing Legionella growth. For larger types of buildings, it's recommended to have hot water heater temperatures maintained above 60 degrees Celsius and have hot water temperatures at distal or endpoints to exceed 55 degrees Celsius. It is recommended to keep this recommendation to keep hot water above 55 is a challenge due to scalding concerns, especially for those at an increased risk, such as children or elderly. As many of you may know, that under the Long-Term Care Home Act, there is a requirement that states that the temperature of water serving residence units in long-term care homes must not exceed 49. So for settings with vulnerable populations, thermostatic mixing valves can be used to prevent scalding. Essentially, these valves blend cold and hot water together to get to an appropriate temperature at the point of use. It is important to consider that these valves can also provide favorable conditions for growth between the valve and the faucet or the tap. And for this reason, the valves should be placed or installed as close to the point of use as possible to minimize the storage of blended water. And cold water temperatures should be recommended to be 20 degrees Celsius or below. However, as we previously noted, there are conditions throughout the system that can cause an increase in cold water temperatures, which would again allow for potential growth. Disinfection is also an important preventative measure. So as previously discussed, disinfection residuals can be reduced at distal points in the system and at the point of use. So some higher risk settings like hospitals or long-term care homes may implement on-site disinfection that may be chlorine chemical disinfection. So we'll move on to cooling towers. So as we saw in the polling question, cooling towers can be the source of large community outbreaks, potentially affecting a large number of people in a small area. As Austin mentioned, Simcoe Muskoka will share their experiences with a recent outbreak involving a cooling tower during the June 8th PHO round session. So cooling towers can be a part of HVAC systems of large buildings that may include large office buildings, schools, long-term care homes, hospitals, or arenas, to name a few. With increasing temperatures globally, we're likely to see more cooling towers in the future as opposed to less. If a cooling tower is a possible source of a cluster or outbreak of illness, it can be difficult to identify cooling towers in the area. Often cooling towers are mainly located outdoors on the ground or on the roof or sides of buildings, and they can be difficult to see from aerial photography. So a physical assessment, street view imagery, or checking with building owners and managers might be necessary in some circumstances. Prior to an outbreak, it can be helpful to have an idea where the cooling towers are located within your area. And the CDC has some great resources online on how to identify locations of cooling towers. And that resource is located in the resources section at the end of this session. So there are a number of different types of cooling towers. There's open and closed circuit systems. This is an example of an open system. I won't get too far into the details of the complexity of cooling towers, but essentially they use the evaporation of circulated water to remove heat. So essentially they're a structure that contains water and a fan as part of a centralized air cooling system for large buildings used to dissipate heat and provide air conditioning to the building. Under certain conditions, biofilm can develop within the system, and warm water temperatures and the large water surface area provides a favorable environment for Legionella growth. And during this process within the system, water evaporates and large amounts of aerosolized water can be discharged into the air. Droplets can be spread as far as 10 to 15 kilometers from the source, so susceptible individuals walking or standing nearby can potentially be exposed. Cooling towers can present a risk when they're poorly maintained or there's a lack of understanding of the system, if there's a lack of regular disinfection, if there's improper restart and operating procedures, or if they're poorly designed in terms of their layout or where they're positioned. For example, if they're located in close proximity to air intake vents or open windows, that can create concern. So we've also know that a source can be a non-potable water system. So decorative fountains can be a source for Legionella growth. As we know, these are systems that are not regulated, so they often lack disinfection, they lack a maintenance protocol, and they often have some form of lighting, which can provide a heating source for the water to increase the temperature. Spas or hot tubs can also be a concern because their water temperature is ideal range for Legionella growth. Disinfection is also rapidly lost because of the high temperatures and high bather load relative to the amount of water. They're often equipped with jets and air blowers, which can generate aerosols. And anyone using the spa are most at risk, but anyone passing by can also create an exposure to aerosols. So there are a number of other potential sources of Legionella that we noticed from our polling question. So really, in the absence of control, Legionella can grow in almost any water system if temperatures are favorable for Legionella growth. So these are just some examples that have been associated with illness. So they include humidifiers, misting devices, birthing baths, dental equipment, ice machines, car washes, medical equipment, soil that's usually linked to potting mixes or garden soils, and hospital dishwashers as well. So we're going to come back to our case scenario for a moment. So after conducting interviews with the 2 new additional cases that were noted, so we now have a total of 3 cases, the public health unit discovers that all 3 cases reported using the shower in their private unit, using the building hot tub, and walking past the decorative fountain in the courtyard. All 3 cases have been found positive by urinary antigen testing, and of the 3 cases, sputum testing is pending for the index case. You can keep this information in mind as we move forward. So we're now going to talk about environmental risk assessment. So now that we know how Legionella is transmitted, potential sources in the environment, and what conditions can allow growth, what do we do when we start to see cases? So we would begin with an environmental risk assessment. So an environmental risk assessment is performed in order to identify possible sources of Legionella. It involves more than simply taking samples and typically occurs before the sampling plans are even in place. An environmental risk assessment is a multi-step process that takes into account a number of factors. So the first being the case exposure history that would have been collected during that initial investigation that Austin referred to. So while we're considering the case exposure history, we want to try to identify any potential exposures and risk factors where Legionella may grow and become aerosolized. So this may include reviewing a building water schematic if cases were residents within a long-term care home or patient within a hospital, for example. So this image that's up on the slide here is from the CDC. It's a fillable form that's available online, and it can be used to document components of the building water system and potential sources of aerosolization to help identify potential sampling sites. Identification of sources will also help to determine the appropriateness of interventions, such as shutting down potential sources. This also helps to guide the sampling strategy that should focus on the connection between the case and their environment to determine possible sources. So as discussed, the environmental risk assessment is a multi-step process and begins before even arriving on site. So our first step is to request to meet with the building owner operator, any maintenance personnel, or anyone that has knowledge of the water system, and any outside water consultants that they may have hired. We want to instruct the facility to temporarily discontinue the use of any aerosol generating items as precautionary action prior to sampling. We also want to advise them not to implement any remediation actions such as superchlorinating, heat shocking, cleaning, draining, or any changing or disturbing of any of the filters within the system. We want to make sure that the samples that will be collected are representative of the potential source at the time of exposure to determine if there is a link to the cases. So then we would move to an on-site visit at the location, and we would conduct interviews. So we want to collect detailed information on any outlets that are infrequently used or there's low flow that can allow for stagnation. Any recent construction or renovation that's happened, because as we know, that can dislodge any biofilm in the water system. And if there's been any changes to potable water quality or any recent outbreaks. We also want to review documents. We want to review any maintenance logs to see if they've had any recent issues or remediation needed on the system. Also, whether or not they monitor the water temperatures or the disinfection levels. If they do, have there been a decrease in either of these that could encourage the biofilm growth? We may also want to look at a building water schematics. We want to know about the incoming water supply, if it's from a municipal source or if it's from a well, and any locations that would create any aerosolizing of water sources. We would then conduct a physical survey. So we would want to, again, identify and assess all potentially aerosolizing water sources as we're trying to kind of nail down where our sampling sites may be. From this point, we would then develop our sampling plan. And this piece we'll discuss in session 2, which is on May 16th. As Austin indicated, there'll be registration to follow for that session. And this is a list of some of the resources that we may have mentioned or referenced throughout the presentation. And I will pass it back to Jenny.
Thank you both, Austin and Kelly, for a wonderful presentation. So it is now time for the Q&A segment of this event to address some of the questions from the audience. And before we begin, just a quick note to our attendees to please continue to enter questions into the Q&A if you haven't had an opportunity to do so yet. And I'd also like to invite Alana Murphy, who is the Senior Laboratory Lead of Environmental Microbiology at Public Health Ontario, as well as Dr. Anna Marjuri, who is a clinical microbiologist at Public Health Ontario, who can address some of the lab specific questions. And Anna will be speaking at next week's session, as well, as Austin mentioned. So I'm just turning now to the Q&A section, and there are a few questions that have already been posted. And there's some additional resources I saw that one of our attendees kindly posted as well. So have a look at that for, I think it was about locating some potential sources of Legionella. Okay, so the first question that I have here is a question about what might prompt a clinician to order a Legionella urine antigen test for a case of pneumonia. Wondering if Austin might be able to address that.
Sure. So when I think of ordering a Legionella test for a patient, I think you need to remember there's a spectrum of disease for legionellosis, and individuals could present with Pontiac fever. And as we saw in the presentation, that's a mild respiratory illness without pneumonia. So a lot of these individuals might be presenting to primary care or their family doctor, and the presentation would be similar to other types of respiratory illnesses that have cough and fever and chills, for example. So I think in these types of settings, Legionella testing is probably unlikely to be ordered for a patient, and the clinician may even inadvertently treat a Pontiac fever without confirming the diagnosis, because the antibiotics that are used are the fluoroquinolones, such as azithromycin, and that's a common antibiotic that's used to treat respiratory illnesses in primary care. So I think when we look to what types of patients get tested for Legionella, it's often those with the more severe disease, so those with Legionnaires who are presenting to hospital and requiring admission to the hospital or the ICU, and that's where the clinician might be concerned about Legionella and order an appropriate test.
Great, thank you. And I see a question that is also related to some of the clinical aspects, and I'm wondering if either Austin or Anna might be able to address this. How long after infection can someone test positive for Legionella?
I can take that one, and that would depend on the type of test that is undertaken for the particular case. So, for example, with the urinary antigen test, it can stay positive for weeks to months after, and that can vary patient to patient. And I think there has even been a documented case where an individual remained positive for up to 1 year. And that's why it's reported as evidence of current or recent infection when we report it out. Culture, of course, depends on resolution of the infection or whether or not the individual has been on antibiotics. And PCR can remain positive a little bit longer than that because, of course, PCR can also detect DNA from organism that is no longer viable.
Great, thank you so much, Anna. There's a question about cluster detection. So prior to the pandemic, PHO had an SDAT pilot using Legionellosis case residence and exposures information from IFAS. Was wondering if PHO plans to restart this tool or other mapping or cluster detection method, or would we be waiting for the transition from IFAS to ODI MSS? Thank you. So just had a quick offline response provided to me, and now that it's post pandemic, I do understand that this is something that the team does want to get back to. So hopefully there will be some more news to share regarding this tool in the next little while. Nothing to share right now, but hopefully in the next coming months. Okay, so there's also a question about in the case study, does discontinuing aerosol generating sources include the site operator asking residents of the building to not use their private showers?
So I can provide a response to this one. So it's very dependent on the setting and the situation. There have been outbreaks within a long-term care, for example, where they have moved to sponge baths, for example, if it's potentially a concern that the shower may have been a source. It's very dependent on the situation, but that is an example of an immediate preventative measure that can be taken.
Okay, great. Thank you very much. The questions keep moving on my screen, so I'm not able to read it. But okay, so one of the recommendations given in this presentation that was mentioned was that hospitals may wish to provide additional disinfection. If a facility opts to install such equipment, would the Ministry of Environment be required to follow up to ensure the system is able to meet potable water requirements? If not, any recommendations as to who would we direct these systems to ensure they are operating properly?
So I can take this on as well. So we would still want to ensure that any facilities that are under a Regulation 170 system are maintained according to the regulations and requirements. We often see, not necessarily often, but with larger systems, they may look to hire a water consultant or a company that can help support the operating of their system. So typically those would be different options to consider using a water consultant, but also ensuring that you're still complying with any requirements under Regulation 170.
Right. Thanks, Kelly. Yeah, so I think, I think the regulation, you should look to the regulation to see what parts of the system it covers. And as Kelly says, in some cases, it may really be a consultant who might be providing some advice on these issues. Is there any consideration in the instruction to temporarily discontinue the use of aerosol generating sources during an investigation, and how to assess and mitigate, and how do we assess and mitigate impacts on the residents? The person asking is thinking of contingencies during extreme heat event and switching off cooling sources.
So with this question, so they're similar to within a long-term care home and the potential impacts that shutting off or turning off equipment might have on the residents. We also need to consider aspects such as this, that if it were to be an extreme heat event, and let's say it's a cooling tower, in consultation with a water consultant or a contracted company, there may be options to remediate while continuing the operation of the system. Again, it all depends on each individual system and recommendations from that water consulting company with plans for remediation. So it's a challenging situation to sometimes navigate depending on what the situation is and the impact that it might have on residents or clients. So there's a number of factors that would be involved in that assessment.
Okay, thank you. There's a couple of questions about recommendations regarding having a registry of cooling towers and health units, and as some of our audience may know, Public Health Ontario really does not make policy or decisions. We leave that to our ministry partners, and so we help to inform with the scientific and technical advice, but do not make the decisions ourselves. So, but certainly, I think I can say that Public Health Ontario we've encountered a lot of Legionella over the past number of years, and recognize that this is an area that many health units and other operators recognize, need further sort of guidance or advice on with respect to managing risk from Legionella. Okay, so going through again some of these questions. How common is severe pneumonia caused by non-pneumophilus species? Have these cases increased recently?
So I would say our disease trends, that's I provided the link for in the chat earlier in the presentation, is just reporting overall trends for legionellosis in Ontario. So we're not doing any examination by not pneumophilus species at this time. So I can't comment if it's increased at all recently.
Thank you. Is there any discussion in the province for legislating water cooling? Recognizing that I think this is probably again addressed by the previous response. Okay, there's a number of questions about sampling. So in terms of prevention, how often do you perform Legionella sampling of major identified sources? And also related, is there a best practice or recommendation document that discusses how to mitigate the risk of Legionella in facilities that require the maximum hot water temperature of 49 degrees Celsius? So a number of questions about best practices and prevention. Maybe Kelly, I know that some of these questions maybe will be addressed at the future session. Wondering if you're able to provide some general kind of principles or tips on preventing Legionella.
Yeah, so I think kind of going back to those kind of key points in terms of temperature and disinfection. And again, it depends on the type of setting, whether or not it's within a hot tub or within a cooling tower or a building water system. And so a piece of that is establishing a water management plan. So prior to any outbreak or any cases. So that's when you can kind of have an assessment of all the different water systems within your facility, and possibly with, again, connecting with a water consultant to determine what the optimal levels should be for temperatures. And I think the question had kind of related back to, I think there was a question about the thermostatic mixing valves. And when those should be implemented. Again, that's a case-by-case scenario, and in some situations where it's a requirement or there's a concern with scalding, that's a piece that you can use as a tool to have the water, let's say in the water heater, set to a limit, let's say it's 60 degrees Celsius, to prevent any Legionella growth. And then you would have that mixing valve at the point of use to have cold and hot water mixed together to prevent a scalding concern. So it really depends on the setting and the type of water system or the type of device that we're kind of looking at. But the key pieces are temperature and disinfection levels and manual cleaning of different systems. It's very general, but we will get into that in session 2 in a little bit more detail.
Sounds good. Thanks so much, Kelly. There's also an interesting question about the potential risk with using aromatherapy diffusers around residents in a long-term care home. Wondering if you might comment on it. It might relate a little bit to what you just spoke to, but.
Yeah, so I can't say that I would have any information specifically on that type of device, but really, if depending on the water temperature within the unit, and if whatever the manufacturer's recommendations are for manually cleaning that unit and replacing the water, you'd want to consider those pieces to ensure that it's maintained so that there isn't any algae or biofilm that's developed within the unit. And if I'm assuming there's likely some aerosolization that occurs. So it may potentially pose a risk, but I can't say offhand that I've come across any instances that would indicate that type of device specifically.
Great. And there's another question asking about prevention measures. Maybe the member of the audience would like to join us for next week's presentation, which will discuss some of the remediation measures commonly used in Legionella. Okay, so a question about whether we have encountered any interesting research articles around Legionella exposures being linked to private vehicle air conditioning systems, especially electrical ones, given that more vehicles are shifting toward electric-only locomotion, and the small protective factor that an internal combustion engine's heat would provide is no longer present. I'm not aware of anything, and I'm just wondering if any of the panelists are.
Not that I'm aware of.
Okay, great. One final one for the PHO lab. PHO lab does not offer quantitative testing that is often offered by private laboratories for Legionella, but only qualitative testing in PCR and culture. Is there any consideration to potentially acquiring this technology in the future?
Okay, I can take that question. And again, we'll be covering more about laboratory testing in next week's session. The quantitative PCR is of highest value for monitoring as a parameter, as one of the many parameters that one would monitor from a cooling tower or other system. And so whereas at PHO, we're not in the monitoring business or the maintenance business for cooling towers or other systems like pools or spas. So we do offer a PCR assay, which is highly, highly sensitive and has a very good predictive value for the sample going on to be culture positive. And we also are primarily looking to identify Legionella within the environment that can be linked at a molecular level to to the case so that we can rapidly address that particular source. We offer it as a screening tool. So essentially, we can screen a number of samples very quickly, and those that are negative, that way that can the PHIs can use that information to direct them away from those sources to those which are positive, and then all of those positive PCR cases go on to culture, or samples go on to culture as well. So it really depends on how you plan to apply the testing and what the purpose of the testing is. So for monitoring purposes, qPCR may be beneficial. You need to also keep in mind that there are no Legionella levels by PCR that relate to infection or outbreak. They're for maintenance purposes only.
Thank you so much, Anna, for the comprehensive answer. And this actually brings us to just over time, and I apologize for the delay. But as we wrap up, I just want to thank Dr. Austin Zygmunt and Kelly Briscoe for presenting. I also want to thank Alana and Anna for joining us during the Q&A segment. And thanks to everyone who joined us for today's webinar. Quick reminder again that this was part 1 of a 3-part series. Watch out for the flyer for part 2 next Tuesday. It will review environmental sampling, interpretation of results, and remediation measures to mitigate Legionella growth in water systems. So registration for this round will open very shortly. Part 3 will be on June 8th, and it will describe a cooling tower associated outbreak investigated by Simcoe Muskoka District Health Unit. So lastly, past access to past PHO rounds presentations can be viewed, and you can view the upcoming sessions as well through the PHO website. Head to Education and Events and click on Presentations. I just want to thank you again for the final time, and have a wonderful day.